Thank you very much and welcome. It's really a pleasure to be speaking to this group, and we're going to be talking today about infectious disease dermatology and mimickers, an update for all of you who are in dermatology day in and day out. I have no disclosures. Let's start with a case. This is this patient who happens to be a Mohs surgeon. Your patient, a Mohs surgeon, develops this rash 8 days after her first mRNA COVID vaccine at the injection site. How do you manage and how do you advise her? And do you advise her to get the second dose or not? So do you want to give her prednisone with no second dose? Do you want to not treat her, but also hold the second dose? Do you want to give her prednisone and encourage a second dose, or no treatment needed and encourage the second dose? Obviously, we're not doing a live audience response, but I'll give you a moment to think it over. And the answer here is no treatment and encourage the second dose. This also applies to boosters and most likely to all future boosters, although of course we'll see as the data emerges in coming months and years. This is the large delayed local skin reaction. It is most common with the Moderna vaccine, as we'll see in a moment, and it is not a contraindication to future vaccine. When we think about the reactions to the COVID mRNA vaccines, it's useful to divide them into immediate and non-immediate. So immediately, if you get urticaria or angioedema within 4 hours, that is indeed a contraindication to getting the next shot. That is a type 1 hypersensitivity, IgE mediated, and it could be correlated with a risk of anaphylaxis. However, any of the common non-immediate conditions that can emerge after the vaccine, includes the 5 that are listed there, are not contraindications to getting a future shot. So if you have a local reaction, including the large delayed local reaction, which, as I mentioned, very common with the Moderna shot, somewhat less common, most likely with the Pfizer vaccine, and then urticaria, morbilliform eruption, and erythromelalgia, they've all been reported. Those are not contraindications to getting another round of the vaccine. A patient develops a cough and this widespread urticarial eruption at the same time and then test positive for COVID. True or false? This rash is an excellent prognostic sign. So the answer here is false. Urticaria is not an independent predictor of mortality or survival. So let's look briefly at the commonly reported COVID-19 associated acute skin eruptions. The first one that was reported is COVID-toes. It also happens to be the most commonly reported one. So chilblains-like reaction or pseudo-chilblains, perniosis-like reaction on the feet and toes. Also quite common is a maculopapular or morbilliform eruption, an urticarial eruption like in that case, a vesicular eruption, looks somewhat varicella-like, and then what's been termed vaso-occlusive. I don't love that term because COVID-toes has an element of vaso-occlusion as well, but this is a severe vasculopathic reaction, including livido racemosa, livido reticularis, or retiform purpura. And these 5 are the most commonly reported, and they are actually listed here in order of their prevalence in the literature. So this is prevalence among reports with COVID-toes at the top. Let's look for a moment specifically at these two, COVID-toes and then retiform purpura, because they are on a spectrum. They're both forms of vasculopathy, and they can be quite useful because of their associations with systemic disease. So COVID-toes typically is associated with mild COVID disease, whereas the more severe forms of vaso-occlusion are associated with more severe forms of COVID. COVID-toes also are more likely to appear late in the course of disease or as an isolated sign. So about 70% will appear long after the development of other COVID symptoms or as the only symptom or sign of COVID altogether. Whereas the retiform purpura is more likely to occur as an early sign around the same time as the onset of other COVID symptoms. And as I said, COVID-toes portends a good prognosis, whereas vaso-occlusive, severe vaso-occlusive disease portends a poor prognosis, so they are quite useful. The other 3 of the most common skin associations with COVID are not terribly helpful. They do not have any known prognostic value. So the key points, just this rapid whirlwind tour of COVID in the skin, are that cutaneous vasculopathy can indeed inform prognosis. COVID-toes has a good prognosis, retiform purpura, bad prognosis, like with most things that present with retiform purpura, and we'll talk more about that later in this talk. And then please don't overinterpret the other rashes, which do not have a known prognostic value currently. And then the delayed vaccine reaction should not preclude any future vaccination. Let's move on to a case here. This is the picture of a forearm of a 54-year-old woman, about 5 days after an excision of a basal cell there. She has progressive peri-incisional redness, pain, malaise, temperature to 100.5. I'm not going to ask you what this is. It has a purple line around it. It's the universal sign of cellulitis. We all know this is cellulitis because of that purple line, and indeed, this is indeed cellulitis. Question, though, is which of the following characteristics is most sensitive for cellulitis? Meaning, if you don't have one of these, you don't have cellulitis. It's tenderness, fever, leukocytosis, pruritus, or malaise. The answer here is tenderness. So if it's not tender, it's not cellulitis. Now, of course, that is a sensitive sign. It's not a specific sign. So lots of things are tender that are not cellulitis. But if it's not tender, it's not cellulitis. And of course, like everything, there are rare exceptions. If a patient has severe diabetes with diabetic neuropathy and they cannot feel their foot and they have cellulitis on that foot, they may not be tender because they can't feel their foot. But aside from conditions like that, if you press on it and it's not tender, it's not cellulitis. So management of cellulitis, the big question is to cover for MRSA or not to cover for MRSA. And to get there, you first really have to ask, is this cellulitis or is it not cellulitis? And then is it severe or is it not severe? Only then can you get to that question of MRSA or not MRSA. So there are many papers showing the costs of misdiagnosis, of overdiagnosis of cellulitis. This particular one was one of several that came out in the same year, and they estimated about 50,000 to 130,000 unnecessary admissions per year because of what's diagnosed as cellulitis but actually is not. And that came with $200 to $500 million in avoidable healthcare expenditures. So this is an algorithm that I use, and I'm sure many of you have a similar one. If nothing else, I think this is useful when communicating with folks who are not practicing dermatology every day. So when I'm talking to primary care docs or hospitalists, I often kind of take them through this algorithm so that they can learn it for the next time. Essentially, is it tender or is it not tender? That's number one. If it's not tender, consider an alternative diagnosis. If it is tender, then is it bilateral? I often will tell the hospitalist that I'm consulting on for these patients, the bug on one leg can't talk to the bug on the other leg. They can't communicate, they can't coordinate their efforts. If it's progressing symmetrically, bilaterally, it's very unlikely to be cellulitis, of course. Is it pruritic as the primary feature, as the primary symptom? Consider an alternative. And then is it geometric? Consider an alternative. So each of these was indeed a pseudocellulitis case. Once you are fairly certain that you're dealing with cellulitis, the next step is to assess the severity. How ill does the patient appear? Do they have severe comorbidities? Or if you try to treat this as an outpatient and turns out to be worse, that the consequences could be very severe. Is there evidence of a deep infection? So if it's severe cellulitis, these patients are all going to get somewhat similar treatment. They're going to be admitted. They should be admitted and observed, debridement if needed, and given broad spectrum IV antibiotics. That's going to cover all of the common pathogens, group A strep, MRSA, MSSA, and sometimes anaerobes and other gram-negative rods as well. On the other hand, somewhat counterintuitively, management of simple cellulitis involves a more complicated decision about whether or not to cover for MRSA. All these patients will get supportive care, but which oral antibiotic to choose? So remember here, we're dealing primarily with group A strep, methicillin-sensitive Staph aureus, and community-associated MRSA, methicillin-resistant Staph aureus. The susceptibility to MSSA and group A strep to beta-lactams is still universal. Now, not all beta-lactams, right? There will be many MSSA strains that will be resistant to simple penicillin, to a first-generation penicillin or amoxicillin. But as you get to the later generation semi-synthetic penicillins, like dicloxacillin, for example, and the first-generation cephalosporins, like cephalexin, cefadroxil, those will cover all MSSA and all group A strep. But MSSA and community-associated MRSA are generally susceptible to trimethoprim sulfamethoxazole, to the sulfa agents, but group A strep is not reliably susceptible to the sulfa agents. And the susceptibility to all the main other classes, clindamycin, fluoroquinolones, tetracyclines, and so forth, will vary. You can't be certain that either the group A strep or the staph will be covered by whichever one of those you choose. Now, there, of course, are some ways to get to certainty. For example, linezolid is going to cover just about all of this, but we don't want to be reaching for linezolid for every case of simple cellulitis that walks in the door. For a number of reasons, side effects, costs, we don't want to be, none of us want to be the one who created LURSA. Well, it actually does exist, at least intermediately resistant Staph aureus, but we don't want to make that worse or reintroduce it. So where do we go? Well, cultures are generally not going to help. They're very low yield. Here's a tour of the data, and it is a bit messy and incomplete, but it is getting better. I'm going to start with 2010, and we'll move forward from there, because in 2010, a Cochrane review came out, and they determined that they could make no conclusions about which antibiotic to choose based on the data that was available up till then. June of 2013, we started to get some better data. So there is, it was a nicely done study out of 3 emergency rooms here in Boston. It was done at Children's Hospital, Brigham, and MGH. And they found that they had 153 cases of simple cellulitis that came into the ED. And the patients were randomized to either get cephalexin plus trimethoprim sulfamethoxazole or cephalexin plus placebo. So everybody got a first-generation cephalosporin, and then half were randomized to get a second agent and half were not. And they concluded that there was no benefit to the addition of a sulfa agent over placebo, same clinical cure rates. Essentially, the exact same study was done on a grander scale in a couple of years later across the country. So 5 emergency departments across the country with 500 cases, and they found almost exactly the same numbers. In fact, no benefit to adding the sulfa agent. In June 2014, some new guidelines came out. These are still the most updated ones. I suspect some new ones will be coming out at some point relatively soon, but these are still the active IDSA guidelines for treating skin and soft tissue infections. They did something good for the first time. They separated out purulent and non-purulent infections, so abscesses from cellulitis. And I just want to caution you about one thing here. In the non-purulent side, cellulitis, when you're talking about mild and moderate cases, which is what we're talking about here, so our outpatient cases for the most part, one of their recommended antibiotics is penicillin. So plain simple penicillin VK orally or IV penicillin. And I'd like to caution everybody against that particular recommendation. So that set of guidelines assumes that strep is dominant in cases of simple cellulitis and that there is minimal contribution from staph, from either MSSA or MRSA. They cite 6 studies total to back that up. 5 of them are from before 1996, so before really the height of MRSA, and they're studies based on culture data, which, as we know, is very low yield in cellulitis and is going to represent only a very tiny subset of cellulitis, a very unusual subset where the bug cultures out from the blood or from the skin. So that's number one. So in studies of culture data before 1996, indeed, strep is dominant, but that does not tell you very much about the 95% of remaining cases that don't culture anything. There was a 6th study, one study from 2010, that did not use culture data. It relied on serologies and beta-lactam response to make that determination that strep was the dominant pathogen. And they concluded that 73% of non-culturable cellulitis is caused by beta-hemolytic strep. They also said that there was a beta-lactam response of 95.6%, which they said backs that up and suggests indeed that strep is the dominant pathogen. But number one, 31% of the cases were lost without serologies. If you were to do they didn't do an intention to test analysis. If you were to do that, you would find that only about 51% were likely to be beta-hemolytic strep from the serologies. The rest we don't know. We either don't know or they were not strep. They recommended the use of cefazolin and oxacillin, which are beta-lactams that also cover MSSA beautifully. So there's no way from the beta-lactam response, from the antibiotic response, to differentiate between strep and methicillin-sensitive Staph aureus. It only suggests that MRSA is less common. But remember also, most people who got cellulitis before the advent of cellulitis did not die from it. Most people recovered. And only a subset did very poorly. So it's very hard to draw conclusions with numbers like were used in this study from the lack of response to antibiotics. And finally, most importantly, perhaps, they only included patients admitted to the hospital. This is a very different population from the population we are treating as outpatients with oral antibiotics. So I don't find this convincing at all that in the population we're talking about here, strep is the dominant bug and we don't have to worry about staph at all, to the point that we can use a first-generation penicillin, which usually will not cover staph, whether MSSA or MRSA in most places around the country. So the bottom line is this is still a moving target, but the data is improving. Anything severe, admit those patients, monitor them carefully, give broad spectrum antibiotics, debride if needed. A beta-lactam is likely best for most simple outpatient cases. There's now plenty of data on that. I would strongly consider, however, a beta-lactamase resistant beta-lactam, not a first-generation penicillin, but a later generation penicillin or a first-generation cephalosporin. Moving on to the purulent side of the table over here, we're going to talk a little bit about incision and drainage for mild abscesses. So there is a brand new Cochrane review that came out just in 2021. They were looking at the efficacy and safety of topical antibiotics versus antiseptics, topical antibiotics versus systemic antibiotics, and one systemic antibiotic choice versus another. And unfortunately, they could not draw any conclusions about any of those comparisons. So the question, though, remains, when somebody has an abscess, should we treat with any antibiotic at all? So let's look at this case here. This was, this patient has a large fluctuant nodule on her forehead there, and you can see some purulent material emerging. There's also some background pustule. There's some pustules in the background, some follicular pustules of folliculitis. This is a case of a furuncle. This happened to be a child with congenital HIV and had recurrent furunculosis. And the question that you see on the screen here, I am actively not asking all of you because it's no longer really a fair question. I used to ask this question for years when I gave this lecture. What should you treat with? Daily chlorhexidine washes, oral cephalexin, cephalexin plus a sulfa agent, IV vanc, or incision and drainage alone? And the answer for many years, but no longer, was incision and drainage alone. But it's not a fair question anymore because of the data that I'm about to show you. So when you have a furuncle, staph is indeed the most common pathogen. You do want to have these patients treat when they're small with just warm compresses. When they're larger than a centimeter or so, you do want to incise them, drain them. And the old teaching was incision and drainage alone is as good as incision and drainage plus an oral antibiotic, meaning there was no need to give an oral antibiotic. But we really do not know that anymore. This was a beautifully done study in 2017 that came out. This is a paper from New England Journal. I don't know how many that I'm speaking to now know me personally, but anybody who knows me personally probably knows that I really love tearing apart our literature. I think there's an awful lot of that's been published that is misleading and not very valuable. This was a very well done paper. It was done in 6 centers across the country, double-blinded, randomized, placebo-controlled, very appropriate inclusion and exclusion criteria, save one issue that I think actually makes their findings even stronger than they realized. They took patients, and I'll explain what that is in just a moment. They took patients who had a single abscess, less than 5 centimeters. It was uncomplicated. They included both adults and children. They incised and drained all of their patients, and then they randomized them to receive either clindamycin or trimethoprim sulfamethoxazole or placebo. They gave appropriate doses of the antibiotics. They didn't underdose anything, and they enrolled 800 people, and they did intention to treat analysis and they got to follow up on almost all of those patients. So very well done. This is a busy slide. I'm not going to expect everybody to read everything, but as you scan through it, these numbers are comparing clindamycin to placebo and then the sulfa agent to placebo. Notice here that pretty much all the numbers are quite large. There was a large advantage in cure rates for the antibiotics relative to the placebo. That's the first thing. I mentioned before that I think they might even be underestimating their data, and that's because the one problem I had with their inclusion and exclusion criteria was that there was nothing in it to differentiate between an inflamed epidermal inclusion cyst and a furuncle. And so by the criteria of the study, I would expect a number of EICs to make their way into the study, and I would not really expect those to get a whole lot better with antibiotics. And so I think that's actually diluting their data. And I think you can get a sense of that when you look at the cases where no Staph aureus was isolated. And I think those probably, I don't have proof, but I think those probably were in large part inflamed epidermal inclusion cysts. Whereas where Staph aureus was isolated, you can see a very large benefit for clindamycin and for trimethoprim sulfamethoxazole over the placebo. Now there is a caveat. So this is just showing again, the green box there is likely more reflective of the antibiotic abscess, the antibiotic impact on true abscesses. Now there's a caveat, and it's buried deep in supplemental table 8. You have to really dig deep to find this problem. It has to do with their definition of failure. So if you look through these causes for failure, conditions that they would consider to be failures rather than clinical cure at 30 days, notice that it includes new infection. So if a patient comes in, they have an abscess, you incise and drain it, and you randomize them to get an antibiotic or a placebo. That lesion goes away and never comes back. But 29 days later, they present again with a new abscess in a completely different part of the body. Is that a failure? This paper considers it to be. They're not wrong, but it really depends on what your goal is of treatment. If your goal is to get rid of that lesion that they came in with, then no, it's probably not a failure. If your goal is to prevent lesions going forward while getting rid of that one, then yes, you have not helped the patient stay clear of all lesions for at least a month after your intervention. So it's an important question though. Is new infection a failure? If you are focused just on the lesion that you treated and forget about new infections that happen over the next 30 days, then redoing those numbers, the benefit of antibiotics goes way down and is not statistically significant anymore. So the big question is, what are you treating? This is a real question. There's not asking for an answer here. You have to think about what are you treating when you are doing an incision and drainage of an abscess? Are you trying to prevent worsening of that original lesion? Are you trying to obviate the need for medications, for oral medications or systemic meds over the next few days? Or are you trying to prevent a new infection? And what you do, depending on your goal, it might be different. So I'll tell you what I do in these cases. When a patient has an abscess that needs intervention, I will incise and drain. I will send a culture, and I will tell the patient that I'm going to call them with the result. And if they're not doing well at the time of the result clinically, I'm going to start an antibiotic, and hopefully we'll have some culture data to go on then, rather than relying on epidemiology alone. If they are doing well, I don't really care what the culture result shows. It could show MRSA, and that's fine. As long as they're doing well, they're not going to need an oral antibiotic. So what they tell me is more important than what I tell them at that follow-up phone call. And that has worked well for me. So far, that's how I interpret this data. It is a different question about whether we should be decolonizing patients, and maybe we'll return to that at the end. But I'm gonna avoid that topic for the moment. So bottom line here, the punchlines here: for purulent disease, for purulent skin and soft tissue infections, abscesses, we have to change the algorithm that's listed in that 2014 publication. We should be considering culture and screen and considering antibiotics for those cases, even the mild ones. And then remember, on the non-purulent side, I would be very cautious about using a first-generation penicillin for cellulitis. Let's move on to another case. This is the most important case for today. I'm going to show you pictures in a moment of a 52-year-old woman with lupus. She was on mycophenolate mofetil and prednisone, and she presented to the ED unresponsive with a rash on her right leg only. She had been fine the night before, and she rapidly developed multi-organ failure in the ED. On hospital day 1, these are her pictures. I'll go through them somewhat slowly. And then on hospital day 3, localized entirely to that right lower extremity. I'm going to pause on this picture for a sec. And I'd like you to pretend that you're in a room with me and that we can actually interact more directly. It's just a lot more fun that way for this part especially. Try to think about if I called on people randomly or asked for volunteers. Think about really enumerating what colors you see here in this picture. So there's some red over here, right? There's purple or violaceous, There's a little bit of black. The black is more obvious in the picture before over here, but there's little specks of black around. And then there's a dusky color, right? There's almost like gray ash spread over the violaceous color over here. So we have a multitude of colors. The red is often going to be a sign of active inflammation. And then the duskiness and the black are signs, are different stages of necrosis. There's one other color here that's a little tougher to see. And I'll give you a second to see if you can notice the other abnormal color in here. And to give you a sense here, the closest thing we have to her normal skin color is this patch of skin right over here, maybe this patch of skin down here. This in the middle here is much more starkly white than her normal skin color. And I'll show you just how white it is in a second. In the next picture, this whole leg is going to rotate down. And actually, you know, I'm realizing now maybe you can't see my pointer. So let me see if I can get a better pointer. Bear with me 1 second, everyone. Can people, at least I can draw it here. This is the area, the white area that I'm talking about. And I'm going to show you just how white it is by rotating the whole leg down for the next picture. And this spot here is going to be lower on your screen. So right here, can you see? So, oh boy, let's go back here. Forget the green circle there. I apologize for not having used that feature before here in Zoom. But look down at the bottom here. That's the patch we were looking at before. Same color as this, as the patch more to the center of her leg. And you can see if you have a large bulla there that erodes, showing the dermis, you can see just how starkly white that dermis is. And this, of course, is the cause of this, the pathophysiologic cause of this whiteness is certainly not, it's not vitiligo acutely, right? This is ischemia. So the colors alone are telling a story here where we have inflammation, we have ischemia, and we have necrosis resulting from that ischemia. The other thing that is important here is the shape. So let's go back to this picture here and notice that the demarcation between every zone, between that white patch and the dusky patches around it, between the dusky patches and the erythematous patches around that, are very sharply demarcated, very jagged edged. You can see that at every stage here. So this is a picture from an old Bologna showing the vascular supply of the skin, showing those perforating arterioles going up through the dermis and supplying a cone of tissue in the dermis, which corresponds to a circle of arterial predominance on the surface of the skin, and then the zones of venous predominance in between them. I'm not a very good artist. Oh, I see that. I need to get rid of that. I need to find a way to get rid of that annotation. Let's see. Bear with me one more sec here, everybody. I apologize. And Elizabeth, if you're listening and can know how I can do that, please feel free to chime in. Ah, got it. Okay. So as you can see from that debacle, I'm not a very good artist. And that will perhaps show here with these diagrams, but I've tried to show schematically what's going on here. So we have a perforating arteriole supplying, going up through the dermis toward the surface. It corresponds to that circle on the skin. And on FOSS, you can see a circle there where there's one, there are many. And in real life, these are not perfect circles. They're more jagged edged, stellate shaped, star shaped. The troughs and peaks might average out to a circle, but they are not truly circular. And again, where there's one, there's many, and many of you know this pattern well. I'm sure you all know this pattern well. In fact, the livido or reticulate pattern that we see in dermatology so often. And the most common time we see this is in livido reticularis, which is, of course, physiologic in the vast majority of people who have it. It's just accentuation of those zones of venous predominance from various things. Physiologic, as I said, in most people, I'm sure a number of people in this audience have that on a cold day. If your leg's hanging off a bench, you'll develop a little bit of livido reticularis. So that's the first thing that can go wrong, so to speak, with the system. You can barely call it wrong, since it is physiologic usually. But the other thing, oh, and it blanches, which I can show here with this fortunate double exposure that you can see here. And the second thing that can go wrong with it, though, of course, is retiform purpura, which we talked about earlier when we were discussing COVID. And this is from occlusion of those perforating arterioles rather than engorgement or accentuation of the zones of venous predominance. So you put a clot in that perforating arteriole, and it causes ischemia of the zone of arterial predominance that it supplies, which begins to necrose, can eventually form a bulla, and then black frank necrosis. So if you have one perforating arteriole that has been hit, you have one patch of retiform purpura, or stellate purpura in this case, since it's just one star-shaped patch. If you have multiple perforating arterioles, of course, you have multiple patches. And they start to blur together, so you can't see all of them as stellate singular patches, but you can still see that jagged edged border. That's the telltale sign. And you can almost imagine where each perforating arteriole is. So in the center over here is one, and somewhere over here is one, and somewhere in the middle of this glob over here is one. So you can start to imagine where those perforating arterioles are. This is a patient who had retiform purpura from a completely different cause. He had vasculitis, and this is a couple of days in. He's in the healing phase, essentially, and all of these patches have eroded and are starting to heal. But it's a very nice example where you can see each of those perforating arterioles that was hit. Some of them as part of a group of neighboring perforating arterioles, all of which were hit, and others that were more isolated, and some areas right in the middle of big areas that were hit that were, for whatever reason, spared, that have perfectly normal skin right next to completely abnormal skin. So jagged edged and extremely well demarcated. So looking back at our patient here, what's going on with her? You can start to see those retiform purpura patches, some individual stellate patches like on her knee, and then that jagged edge of the areas where there are more grouped patches of retiform purpura. You can start to see it here again. So let's start to figure out what she actually has. And I will tell you, ultimately, her actual diagnosis is going to be the least important part of this case. More important is going to be the differential, and you'll see why in a minute. So this patient, remember, had lupus. She was immunosuppressed, and she presented with terrible vital signs. So temperature of 104.6, pulse in the 140s, systolics in the 80s. She was unresponsive with that rash on her right lower extremity. She had pretty terrible labs as well. She had acute on chronic anemia, acute on chronic thrombocytopenia, acute on chronic leukopenia, and acute on chronic renal failure. So pretty terrible all around in her presentation. She was very, very sick. So let's think about this pathophysiology. We have a clot in that perforating arteriole causing necrosis. You can diagnose that just by looking. So as soon as you see retiform purpura, you can diagnose it as retiform purpura. That perforating arterial clot has to be caused by either an embolism or an in situ thrombosis. Nothing else can cause a clot. So we're left with one of those two. If it's an embolism, it can be any embolism, air embolism, cholesterol embolism, amniotic fluid embolism. So any embolism can cause it. I find it useful to further subdivide the in situ thromboses into vasculitis or hypercoagulable state. And then I find it further helpful to divide the vasculitides into an inflammatory vasculitis, which is what we usually think of, and then septic vasculitis. So vessel invasive organisms, angioinvasive organisms. So you can diagnose retiform purpura just by looking. You don't need anything else. And the second you do, you know right there and then that that patient either has an embolism, a hypercoagulable state, a septic vasculitis, or an inflammatory vasculitis. So it's very useful for morphology. This is a relatively, it's not a truly comprehensive, but it's a moderately comprehensive chart with the common diagnoses that can cause retiform purpura. I'm not going to read everything, but as you scan through this, as you look through it, I want you to notice two important features. Number one, nothing on here is a primary cutaneous disease. Everything is a systemic disease that happens to affect the skin. I need to add COVID to this list, by the way. I'm sorry that I didn't, but COVID, another systemic disease that may sometimes affect the skin. So no primary cutaneous diseases. Number two, they're all bad. You really don't want any one of these entities on this list. So again, you can diagnose retiform purpura just by looking. And the second you do, you know that you have something systemic and bad. Now, this patient who's coming in, obviously we know she has something bad. She's very, very sick, but a patient might present with one little patch of retiform purpura on a finger, half a centimeter across, maybe a low-grade fever. That's a Janeway lesion until proven otherwise. Everybody who has retiform purpura, if they're not sick, they have potential to become very, very sick within a short period of time. So it's always something to be taken taken seriously. With this particular patient, when I broke her down, when I was trying to figure out what she had that night in the emergency room when I met her, I was concerned because I had 3 particularly bad entities on my list, and I wasn't sure at all which one it was going to be. I wasn't sure if she was going to have something called catastrophic antiphospholipid antibody syndrome, or the so-called thrombotic storm that can happen in lupus, or TTP, thrombotic thrombocytopenic purpura. She actually met all criteria for TTP. You don't need nearly all of them to have TTP, and she did have all 5. And systemic infection, either causing sepsis with DIC, causing retiform purpura, or having embolic showers to the right lower extremity, or just an organism progressing along the right lower extremity, along that limb that was also vessel invasive, so an angioinvasive organism. Fortunately, the answer came quite quickly. She grew later that night 4 out of 4 bottles of gram-negative rods. On biopsy, she had sparse gram-negative rods on the gram stain. And ultimately, she grew out Serratia marcescens, which is an uncommon pathogen for the skin. It's usually a urinary bug. When it's not urinary, it's usually pulmonary. Her source actually turned out to be GI, and an emboli and a likely embolic event seeded the leg, and then it spread rapidly along that leg. But the key thing here is not to remember Serratia marcescens sepsis with a necrotic retiform purpura of a seeded limb. That's not what I want people to take away from this case. What people should take away from this case is the ability to recognize retiform purpura in its severe or mild forms and recognize its severe implications. So some more faces of retiform purpura just to make sure everybody is comfortable with it. This was a patient who was several days post-procedure from a vascular procedure. This was from cholesterol emboli. Again, totally normal skin right next to totally abnormal skin and a very jagged edge in between. And you can almost make out the outline of each stellate patch around the periphery and imagine where that perforating arteriole is. Same patient here. And again, you can see some areas of sparing and then another couple areas that were hit. If you're going to biopsy these to figure out the cause, a few notes that are worth thinking about. This patient, probably too late to find a whole lot on biopsy at this point. You want to try to get it early. And this is one of those cases where you don't want to biopsy the edge of a lesion. Most things in dermatology, we want to biopsy a leading edge, which is where the pathophysiology is most likely to lie. In these cases, the pathophysiology is going to lie within that perforating arteriole somewhere near the center, but you don't really know exactly where the center is. So the ideal situation is to find an early small patch of retiform purpura and take the whole thing, or at least the whole middle. So do a big biopsy that takes the whole middle, and you got to go deep, and you want to try to get that perforating arteriole in the biopsy. So that's your goal. So I would take generally I do more than one biopsy in these patients. When I need to biopsy them, I try to do at least 2, and I try to find whole small lesions where I can get the whole thing in a relatively small biopsy, like a 6mm punch or an 8mm punch biopsy. And I go deep. Another patient here, this patient had E. coli sepsis with DIC. Now, the picture on the left here is her thigh close up. If you saw just the distal aspect, all you would be able to say is that she has a purpuric limb. And that's somewhat useful, but not that useful because the differential diagnosis for purpura in general is really very large. But when you look at the edge, where you see that island of sparing, now it's not just purpura. Now it's retiform purpura, which has a more limited differential. It's still big, but it's not nearly as big as the differential diagnosis for purpura in general. Retiform purpura is much more useful. It's a subset of purpura, but it tells you much more about the patient's condition. So if you look distal on her leg, all you know is that she is purpuric and necrotic. If you look proximal to the thigh, now you can tell she has retiform purpura, and you know she has an embolism or an in situ thrombosis. And in this particular case, she has in situ thrombosis from DIC causing hypercoagulable state. Another patient with DIC from E. coli sepsis. Another patient here with E. coli sepsis. And then I For a long time, I was very hesitant to put this picture in my talks because it's a terrible photo. It's completely out of focus. But I keep it in because it proves the point that you don't need focus to diagnose retiform purpura. It's a 20,000-foot view diagnosis. You can see it even with blurred lines. You can see here this patient's, these patches on the back of her hand are pale in the center. They are violaceous around the periphery, and indeed, if you press on them, they are purpuric. You can see the shape, that jagged edge. This is a patient who had multiple hypercoagulable states that were on top of each other, essentially. And she had AT3 deficiency, antithrombin 3 deficiency, and factor V Leiden, I believe, if I remember correctly, and then actually had a malignancy at the time of this picture. And so they all stacked on top until she developed retiform purpura on her hand and also on her leg. So key points here are, number one, to recognize retiform purpura, those well-demarcated purpuric patches with jagged edges and violaceous, dusky white or black patches that ensue, and with evidence of necrosis, and that it's an early indicator of a systemic, generally malignant process. Malignant here not meaning cancer, but meaning severe, dangerous, sinister. Let's move on to the next case. This is a healthy 18-year-old male who presented with a day of a worsening pruritic rash on his face. In the ED, he was diagnosed with impetigo. He was admitted to the ED observation unit for IV antibiotics. And the next day, his rash extended toward his lip and his eye, and derm was consulted. Now, a few things before we even look at pictures. When I was walking down to see this patient in the ED, there were a few things going through my head. Usually, the ED does not admit somebody even to the OBS unit for impetigo. Usually somebody with impetigo does not get IV antibiotics. So what I know when I'm going to see this patient is that a smart, well-intentioned doctor or nurse practitioner or PA is worried about this patient. They may not know exactly why, they may not know exactly what's going on, but something funny is happening here. So going to see this patient. And he is markedly edematous. He actually can't open his eye properly because he's so swollen. You can see that gold encrusting on his earlobe, and that's of course why he was diagnosed with impetigo. And indeed he has impetigo, but we in dermatology know that impetigo in a healthy adult is not a primary diagnosis. It's a secondary diagnosis. Kids can just get impetigo sometimes, but adults really need to have a reason to get impetigo. They need a break in the skin. They need an abrasion that gets impetigonized. They need eczema that gets impetigonized. They need to be immunosuppressed, predisposing them to otherwise spontaneous impetigo. They don't just get impetigo. So impetigo here, yes, he has it, but it's a secondary diagnosis. So why does he have impetigo? Well, he's got that swelling. Let's look around. You can see here he's actually quite happy. By the way, I forgot to mention, they also said that because the rash was extending toward his lip and his eye, they were worried about SJS and toxic epidermal necrolysis, which we can see, of course, he does not have. This is not SJS, this is not TEN. So he's smiling here, he's quite happy, but he can't open his eye. He's very swollen. So let's look more closely in at that ear. And actually the key feature in this slide is not the impetigo itself, but it's just anterior to the earlobe. He's got that cluster, tiny little vesicles, tiny. Not a whole lot of erythema around them. This doesn't really look herpetic. To me, at least, it's not, it's missing the rose petal of dewdrops on a rose petal of HSV or VZV. And the blisters are really tiny here. They're smaller than typical for HSV. You can also notice that my camera flash is shining back at me on the more medial aspect of his face that's in this picture. And that's of course because he's wet. So the skin is so edematous, it's actually leaking fluid onto the surface. And that's causing the flash to shine back at me. And if any of you in the audience right now happen to speak Greek, and specifically ancient Greek, if you happen to know the root of the word eczema, if we were live now, I'd ask you to shout it out. Because eczema actually comes from the Greek for boiling over, bubbling out, boiling over. And the acute stage of eczema is the boiling over stage, where you have so much spongiosis in the epidermis that the fluid begins to bubble out through the stratum corneum and onto the surface. And that's, of course, why we have impetigo on top of eczema, because that fluid that comes out is great food for staph bacteria. Staph aureus bacteria, aureus coming from the word for golden, that golden color. So we're starting to see here with that edema, those tiny little microvesicles in front of his lobe from the fluid bubbling out from that boiling over phase of eczema, that he has impetiginized eczema. Why does a healthy 18-year-old suddenly get impetiginized eczema severe enough to land him overnight in the emergency room? So we look around at the rest of his body, and you can see he's got more of a rash here by his axilla and his abdomen. And then we get to his flank, and we see these lines, and they are not actually parallel with each other. These three are somewhat parallel or close to it, but there's another one up a little bit more superior that's aiming down toward the other three lines. We have more here that are not parallel as well. So outside job, right? If we have these straight lines at an outside job, and it's probably not just his fingernails, because we tend to scratch in parallel lines. It's very unusual to have kind of a cluster of three and then one going perpendicular to that when it's just from scratching. So I'm sure many of you in the audience now know exactly what this is. This was a pruritic eruption coming out in lines in his flank, and of course it was poison ivy. So he had severe impetiginized poison ivy. Now the interesting thing was he was in the observation unit of the ED. About 40 feet away in the alpha unit of the ED was his girlfriend, looking exactly the same. They had not told their teams that each one was there. So his team consulted derm, her team consulted allergy, and then they told us about it. We met in the hallway between alpha and obs and exchanged notes. And these two had been rolling around the day before and in the park and gotten some severe poison ivy. They both did very well with some topical steroid. I'm going to skip that slide and move on to this related case. This was a 44-year-old man that I met on the inpatient unit. This is at Brigham and Women's Hospital before I was at Leahy. And he had this, well, I don't know what he had originally. I never saw him originally 3 weeks prior to this picture. He had something on his arm that he thought was an infection. So he went to his uncle, who is a primary care doc, or a doctor, I actually don't know what kind, and his uncle gave him an antibiotic, gave him cephalexin. He didn't get any better. So he went to his actual primary care doc, who said he had a cellulitis and gave him clindamycin. He didn't get any better again. So about a week later, he went back and he was given trimethoprim sulfamethoxazole for presumed MRSA cellulitis, and a swab was taken from the surface. 2 days after that, he still wasn't any better. It was getting worse. It was looking like this now. The swab was no growth to date, and he presented to the ED and was admitted to the hospital. And the plan was admit for IV PICC line for vancomycin for 2 weeks for presumed MRSA cellulitis. He actually demanded the derm consult, so that's when I got to meet him. And the first thing, well, let me ask this. Think about it for a second. If you are seeing this patient, imagine you have time for one action. You can either ask one question, you can do one exam maneuver, you can only do one thing. And he's about to go get a PICC line for vancomycin for 2 weeks. What do you want to do to figure out if that's appropriate or not? So I would argue if you only had one thing to do, you want to mash on this, press on it. Does it hurt when you press on it? And the answer was no. This was not tender. So immediately abort the PICC, right? This is not cellulitis. Cellulitis is tender. If it's not tender, it's not cellulitis. So now we start thinking, well, what is it? And it turns out it was itchy primarily. It was non-tender. And when you look closely here, we have this edematous, erythematous plaque. There's an erosion in the center, and around the periphery of that erosion are tiny little micro erosions. And where there were micro erosions, there are micro erosions, there probably were micro vesicles. There's some gold encrusting. So overall, we have a picture here of a boiling over rash. So this is a rash that was so much fluid that it was causing edema, and it was bubbling out through the surface, causing tiny little microvesicles that then coalesced into larger vesicles and erosions, and feeding Staph aureus bacteria and causing some impetigo. So we're dealing again with an eczema of some sort. So why does a 44-year-old healthy man get a severe enough eczema on his forearm to be admitted and to almost get a PICC line for 2 weeks? Well, what do we do when we think we have an infection? Not us in dermatology as much, but still we do it too. And certainly outside of dermatology, it's extremely common. We put on triple antibiotic ointment. which of course has 2 of the top 10 most common causes of allergic contact dermatitis in the country, neomycin and bacitracin. So again, I don't know what this lesion looked like originally, but by the time I met him, he had a rip-roaring allergic contact dermatitis to bacitracin or neomycin, perhaps both if there's a co-sensitization, and he did great with a little bit of clobetasol, and he went home with an hour later. And then the final picture I'm going to show, or final patient, is another similar case, a patient I met. This is actually at Beth Israel Hospital. So this is not specific to any place. This happens everywhere. This patient was admitted with this very, very large ear. I wish I had a picture of his other ear to show. This ear is literally twice the size of his other ear. It is massively edematous. He had been in the hospital for a week by the time I met him, getting IV antibiotics for presumed otitis externa, and he wasn't getting any better. First thing I did, I mashed on his ear. I didn't grab it, rudely, but I grabbed it, and it did not hurt. It was not tender. So we pieced everything together. Turned out his family was very smart, very doting. They had read up all about otitis externa. I don't know exactly what he was admitted with initially, but they learned that otitis externa is often caused by a bacteria called Pseudomonas, and that Pseudomonas responds to a few antibiotics, one of which is neomycin, another of which is polymyxin, both of which are in triple antibiotic ointment, and they had been sneaking it into the hospital and putting it on his ear generously and liberally and frequently, about 5 times a day. And this was another case of rip-roaring allergic contact dermatitis to triple antibiotic ointment, and he also went home about an hour later with clobetasol and did fantastically well. So this is just the posterior aspect of his ear. So the take-home points here are, number 1, skin reaction more than 4 hours after a COVID vaccine does not preclude future COVID vaccine doses. Number 2, cellulitis is tender. Number 3, recognize retiform purpura and its implications. And number 4, of course, we all know triple antibiotic ointment causes contact dermatitis. I thank you very much for those of you who invited me to this group, and to my patients who've allowed me to photograph them for the benefit of others. Now, I just learned immediately before this talk started that this talk can go longer. So what I might do is give an optional few minutes for another case that I don't usually get to present. I think I'm just going to go through this very quickly, and the organizers can cut this part out if you want, and anybody who's watching can, of course, stop at any point. But there's at least a small important point here from this case, so I'm going to go through it quickly. I'm going to show you pictures in a moment of a 49-year-old male with 5 weeks of a pruritic rash. It involved pretty much all of his skin except for his palms and soles. They were spared. He had a couple tongue sores, and he had some discharge from his eye and low-grade fevers nightly for several weeks, associated with some myalgias, headaches, and lethargy. Past medical history notable only for bipolar disorder, but he was stable off medications for several years, and he was only on, as you can see there, intermittent diphenhydramine, lorazepam, and sildenafil. This is his rash. You can see these are scaly papules over most of his body. And at least some of them are follicular. You can see hairs coming out of some of them directly, and then this spacing overall is suggestive of a follicular eruption. You can see that again over here. But he also has it on his glans penis, where there are no follicles, of course, so it's a follicular eruption, but not entirely follicular. What's our diagnosis here? Syphilis, psoriasis, pityriasis rosea, measles. Well, I'm going to give you, before I give you the answer, the initial workup. So in the ED, I had blood drawn for an RPR, for an HIV ELISA, and for a skin biopsy. No, I did a skin biopsy. And RPR was negative, HIV was negative, and the skin biopsy showed a lichenoid and superficial and deep lymphohistiocytic infiltrate with plasma cells and granulomas. So sorry, superficial and deep a lichenoid infiltrate, and then a superficial and deep lymphohistiocytic infiltrate. So 2 separate reaction patterns with plasma cells and granulomas. So what do we think the diagnosis is now? Does that change anybody's mind about the cause? So I'm going to give it away now. The diagnosis here is indeed syphilis. So why do we have the negative RPR? So let's just talk for a second. Why am I even taking the time to present a case of syphilis at all? So I'm sure you're all aware that we are in the middle of a bit of a syphilis epidemic. After it was really under excellent control for many years, rates have been rising steadily for the past 10+ years. Now notice something here. If you look at from 2015 through 2019, of course, men make up the bulk still of cases of syphilis. Women are a minority of cases, but the rate of rise is interesting. So the rate of rise for men, somewhere around 48% rise over that 5-year period. For women, it's a 179% increase, 180% increase over that same time frame. They are rising. The rates of syphilis among women is rising much faster than the rate of rise of syphilis among men. And women are making up a larger proportion of the pie, so about 16.5% now of cases. And that's important for a number of reasons, but one of which is congenital syphilis, that women of childbearing age can become pregnant. And when they have syphilis while pregnant, that can cause congenital syphilis, which is a devastating condition that has lifelong implications. So a single baby born with congenital syphilis has the implications for society, for that child, equivalent to, no matter how you measure it, essentially quality of life years, all kinds of different ways to measure, equivalent to many adults who get syphilis where you can treat that syphilis. So it's a really big deal when even a small number of people start to be born with congenital syphilis. And as that rate of women with syphilis rises, this becomes a bigger issue. So we have an epidemic. It's rising fastest among women, and congenital syphilis is rising in parallel, and the diagnosis can be tricky. This is missed not only by internists, but by dermatologists often as well. So again, now let's come back to that question of why the false negative RPR in this case. So this was because of something called the prozone phenomenon that's worth filing away in the back of your minds, because when it happens, it can fool you if you're not aware of it. So this only happens with the non-treponemal tests. So RPR, VDRL does not happen with the treponeme-specific antibody tests. The way those tests work, the way the RPR and the VDRL work, is the treponeme, the syphilis bacterium, incorporates and modifies host cardiolipin, and then the host will produce antibodies to that modified cardiolipin. So the test, essentially, it's a form of an anticardiolipin antibody test. You're going to take the patient's serum, you're going to incubate it with some cardiolipin, and that's going to cause precipitation or flocculation of the antibody cardiolipin complexes. You can have false positives, therefore, from any other source of cardiolipin. So sometimes in lupus, for example, you might have a false positive. You can have false negatives if you're just too early to test, if you're much too late where that reaction has died down already years after infection, patients who are so immunosuppressed they can't form the antibodies, or because of this prozone phenomenon, which is when you have a notable antibody excess preventing agglutination, preventing flocculation. You're not going to form that solid to precipitate out of the solution to then turn the test positive if there's a huge imbalance in the number of antibodies versus antigen in your sample. So patients who have a ton of antibodies can test falsely negative. The fastest way to check if a negative RPR is truly negative or if it's from the prozone phenomenon is what we did in this particular case, is to dilute the RPR. You can just ask the lab to begin to do serial dilutions and retest. So this patient turned floridly positive at an RPR dilution of 1 to 16. So when you diluted the serum to 1 to 16, the RPR suddenly turned positive. Risk factors for prozone phenomenon, the reason I'm bringing it up here, neurosyphilis and pregnancy. So again, that population that is of particular concern because of congenital syphilis is also the population that is at highest risk of this phenomenon of being misdiagnosed or underdiagnosed because of the prozone phenomenon. And then alternative means to test that are not subject to the prozone phenomenon are the treponemal specific antibodies, and different institutions will have different mechanisms, different algorithms, whether to test with a non-treponemal specific test first or a treponemal specific test. And this going back and forth, there are pluses and minuses to doing each type of algorithm. Some actually will just do two different treponemal specific antibody tests without ever doing the non-treponemal. But there's a good chance that a non-treponemal test is at least part of the algorithm at your institution, and that would be subject to this prozone phenomenon false negative. PCRs from the blood or tissue are also not subject to the prozone phenomenon. Dark field microscopy, nobody does anymore. And then silver staining of tissue, and indeed this patient, this was his biopsy, this was the silver stain, and he had quite profound secondary syphilis. Final pearls, why did it spare his palms and soles? This is the picture I have here is not this patient. This is the patient has a classic appearance of those ham-colored macules of secondary syphilis on the palms. Why did our patient have it everywhere except for his palms and soles? So when you look at the many variants of syphilis, of course, it can come out in all different ways. As we know, it's the great mimicker. There are a number of ways that are common enough to be called syphilids. They are common enough to have their own named entity describing how they emerge. And one of those is the follicular syphilid. So it targets, for whatever reason, follicles. And so that's why this patient, first of all, had a follicular eruption. And second of all, while it spared several of the areas that do not have follicles, his palms and his soles. Now, it did not spare his genitals, did not spare his tongue. So it's not 100% by any means, but that is most likely why he had it spared his palms and soles, because he had this follicular syphilid, which you could see in that follicular pattern of his scaly papules. So the key points here: rates are rising, cases are being missed. Presentations vary, of course, that's an understatement for syphilis, as we all know, and there's no test or algorithm that is perfect. So don't rely on your test 100% when you have a high pre-test probability. If you are suspicious, go with your suspicion. Clinical is going to lead you oftentimes better than a lab test. And maintain a high index of suspicion and retest if you're concerned. Thank you all very much for your attention.